Cast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our third Thursday webinar. I'm Margot Hoffman with the Partnership for Excellence, and on behalf of our sponsoring programs, I welcome you to our webinar. Our programs include the California Council for Excellence, the Oklahoma Quality Foundation, Partners in Performance Excellence Northwest, the Rocky Mountain Performance Excellence, Sterling International, and then my program, the Partnership for Excellence. We're excited to have Dr. Naifah Hamoudah here today to do a presentation on clinical governance as a catalyst for excellence. Before we get started, I have a few announcements. First of all, there is a copy of Dr. Naifah's presentation. If you pull down the pull down screen, you'll see there's a place where there's materials, and we have uploaded a copy of the presentation if you'd like to access it. We are also recording this presentation, so we will provide a link to the recording after the webinar is over. If you have any questions throughout the webinar, please type your questions in the question box, or you can put them in the chat box, and I will ensure that Dr. Naifah receives those questions. We have a couple announcements to make, and then we'll have our presentation, and then we will conclude the webinar with questions and answers on the presentation, and then introduction of our next webinar. Just to remind you, all of our programs have events throughout the year, and we have web pages that share our events throughout the year. So please access the events pages with our programs and join in and participate in some of those events. We'd also like to thank our organizational members. Most of our programs are 501c3 programs, and we're extremely grateful for the support that we get from our organizational members to do the work that we do to promote performance excellence. I would now like to share a little bit about our presenter. It's my pleasure to introduce Dr. Naifah Hamoudah. She's one of the most dynamic leaders who is passionate about advancing excellence in healthcare today. Dr. Hamoudah is the Executive Director of Governance, Risk, and Compliance and International Audit Advisor at the Ministry of Health in the Kingdom of Saudi Arabia. At Sterling International, she serves as Chief Evaluation Officer, Board Member, BOA Synthesist, and Sterling International University faculty. With more than 17 years of advanced experience, she has led major transformations across public and private health systems, strengthening strategic planning, accreditation, performance excellence, risk management, and clinical governance. She contributes to multiple national programs and serves as a surveyor and advisor under the Kingdom's 2030 vision, advancing quality, safety, and organizational excellence. Dr. Hamoudah is a physician with plastic surgery background, a certified GRCP professional, GRCA auditor, and a certified green belt in value-based healthcare. As a Sterling certified synthesist, she brings a powerful combination of clinical insight, systems thinking, and operational excellence. She is widely recognized for helping organizations assess their current state and design high reliability, future-ready systems. Please join me in welcoming Dr. Hamoudah. Okay, and let me get her set up here.
Hello, good morning, everyone. Thank you, Dr. Hoffman, for you. This is for the nice introduction. It's my pleasure to be with you today to explore the clinical governance through a performance evaluation lens. In this session, we will move beyond basic definition and look at how clinical governance become a catalyst for organizational excellence reliability, and system-wide. So here, our roadmap for today, we will begin with setting the context, why clinical governance has become a central capability for modern health system. Then we move toward the end. We will look at the advanced and the future focused topics, governance in complex system, and high reliability and foresight. And we will close with the key takeaways and call to action. In this slide, you can see where is governance in Stirling-Baldrige framework. So clinical governance aligns directly with the several parts of the Stirling-Baldrige framework. Governance is not isolated. It is embedded across leadership, strategic context, measurement, and results. Category A reflects the leadership roles in setting expectation for safety, quality, and accountability, and ethics. Category 4 reflects the system for measurement, analysis, and knowledge management, which underpin governance intelligence. Category 7 reflect the results and the outcomes that prove whether the governance is functioning effectively. And the organizational profile sets the context, the population needs, high risk pathways, and regulatory expectations. So clinical governance lives across all of these areas. So in organizational profile, it answers who are we and what matters most. This is the foundation for clinical governance. It identifies the population needs, burdens of disease, high-risk pathways like NICU, ER, ICU, oncology, and OR, as well as the strategic priorities for safety and quality. So regulatory and accreditation expectation also sit here. In clinical governance, the organization profile is what sets the baseline for identifying risks, expected competencies, safe staffing requirements, and the areas where the variation must be managed. Without an accurate organizational profile, governance is blind. It cannot be anticipate risks or set priorities effectively. Here you can see the heart of clinical governance. So in category one, we focuses on the leadership role in shaping mission, vision, values, and the governance system. This is directly aligned with the clinical governance because leadership is ultimately accountable for quality and safety outcomes. So leaders must model transparency, ethics, and accountability, and culture of learning. They establish the governance structures, committees, escalation pathways, oversight systems, and in practice, the leadership commitment is the strongest predictor of clinical governance maturity. So strong clinical governance requires leaders who actively oversee risks, safety, and performance, not just approve policies. Okay, so here, this slide gives concrete examples of where, it will give us the concrete it will give us concrete examples of where clinical governance fit into leadership routines. These include the CEO chaired the quality and the safety committees, the executive level GRC oversight, the leadership walkarounds, safety culture programs, incident escalation pathways, clinical risk registers, and sentinel event governance. So clinical governance is equal leadership in action. Now, the category 4, it addresses the intelligence system of clinical governance. It focuses on the data integrity analytic capability, predictive modeling and learning system, and relies on accurate, timely intelligence. This includes validated KPIs, incident data, risk dashboards, early warning system, and performance trends. So category 4, it represents the shift from reactive oversight to proactive prediction and prevention. Here, as you can see, this is the list of specific clinical governance elements supported by category 4, such as mortality, VTE, sepsis bundle, ER triage, pressure injuries, medication errors, infection rates, and in ICU indicator. It also includes the dashboards, the clinical audits, the early warning signs like mouse, competency compliance, incident reporting system, and the value-based healthcare outcomes measure. So when category 4 is strong, the clinical governance become proactive, predictive, not passive or reactive. Here, this is the evidence of the Sterling International criteria requires evidence of result, not just policies or committees. So it focuses on the result, the ultimate test of whether the clinical governance is effective. The governance is not measured by the number of committees or policies. It's measured by the outcomes. These include the patient safety indicator, sentinel event, near misses, clinical effectiveness, patient experience, work competency, and operational efficiency. Also, we will not forget the financial impact, such as the cost of poor quality. So, category 7 brings accountability. Clinical governance must demonstrate improved outcomes, not just activity. Here, where clinical governance and Sterling meet, this is emphasized that the integration is the center of both the clinical governance and the Sterling model. So clinical governance integrate the leadership, risk management, quality assurance, patient safety, continuous improvement, data, workforce, patient voice, strategic planning. So all of them, they are included. So Sterling calls this, what they call it, integration, aligning processes, results, learning across the system. So the clinical governance is operating system for clinical excellence. Now, the clinical governance is defined as an integrated framework through which the healthcare organizations are accountable, improving the quality, safety, the effectiveness of the clinical care. It ensures that the high standards are maintained and that the organization establishes an environment where excellence is clinical practice can thrive. The definition emphasizes 3 elements: integration, accountability, the continuous improvement. So it's not, the clinical governance is not a project or a department, it is a system that governs how care is delivered, monitored, improved across the entire organization. Here you can see the purpose of the clinical governance, which is to ensure patients receive safe, effective, person-centered care. It embeds the accountability for safety quality at every level of leadership, not just the clinical level. The clinical governance aligns the clinical performance with the organizational value and strategy. Ultimately, the purpose is to move from reactive, incident-driven management to proactive, prevention-focused improvement. Here, you can see that the clinical governance defines who is accountable for quality and safety, who decisions are made, and how assurance is provided. So effective clinical governance requires clear authority, decision rights, reporting expectation, and transparent escalation mechanism. So governance failures are often system failure, not an individual failures. Leaders are responsible not only for results, but also for creating the system that produce reliable results. So when accountability is unclear, risks go unmanaged and outcomes become inconsistent. Here, the continuation highlights that the leadership must build governance system that enable reliability. So leaders must ensure that structures, policies, accountability pathways, and reporting framework exist and are functioning. So the success lies not in having committees, but in how leaders use these committees to make decisions, anticipate risk, and drive improvement. Okay, so clinical governance operates at three interconnected levels: the board executive level, the organizational committee level, the clinical service unit level. At the executive level, leaders set strategy, define risk appetite, and receive escalations. While at the committee level, groups such as clinical governance committees, quality committees, patient safety, mortality, morbidity, and infection control translate the strategy into an oversight. At the unit level, frontlines team own daily quality and safety. So alignment between these three levels is essential. That means fragmentation creates variation and integration creates reliability. Here, it's very important slide, the 7 pillars of clinical governance. They are the pillars that build the clinical governance. They represent the operational backbone of the clinical governance. It is the clinical effectiveness, risk management, patient safety, patient experience, education and competency, and clinical audit. And the last one is the information and data. These are interdependent weaknesses in one create. So if there is any interdependent weaknesses in one, creates a gap in the entire system. So for example, strong clinical audit without strong data means leader cannot see trends. So strong training without safety culture results in underreporting. Effective clinical governance require all these 7 pillars functioning consistently. We will start with the first one is the patient safety and risk management. It includes the proactive, reactive, and predictive activity. So proactive approach involved hazard identification, risk register, process mapping. The reactive one approaches include incident reporting, near misses learning, and the RCA. And the predictive approach involve trend analysis and early warning indicators. The aim is not to eliminate reporting, but to increase the reporting while reducing the harm. High reporting with low harm is the sign of healthy safety culture. Okay, so clinical audit provides formal assurance that the clinical practice aligns with the evidence-based standard, and effective clinical audit are focused, standard-based, action-oriented, and followed by re-audit. So the audit finding must be linked to the governance committees and the executive, ensuring oversight and action. So audit without an action is not governance. Regarding the information, here the governance intelligence depends on clear definition, accurate measurement, and a strong analytics capability. So effective dashboards include balance of outcome, process, and balancing measures. Leaders should focus on trends, not snapshots. Data must answer, what do we need to do definitely? So clinical governance depends on decision-grade data, meaning valid, timely, contextual, and actionable intelligence. Too many metrics create noise. The right metrics enable clarity and focus. Here, the culture, just culture, and the learning system. So, a strong clinical governance system requires a just culture where the individuals are accountable for their behaviors, but not blamed for human error. Psychological safety is essential for open reporting and learning. Leader must promote transparency and improvement. So organizations typically evolve from blame culture to reporting culture, and the ultimate goal is a learning culture. Culture is the invisible infrastructure of the governance. Without it, systems don't perform reliably. Here you can see in this slide, it introduced the three maturity level of clinical governance. Level one is compliance-driven organization focused on policies, incident response, basic documentation. Level two is assurance-based with structured committees, regular dashboards, and improving reliability. Level three is a learning and high reliability system where predictive risk management, integrated data, and sustained improvement define daily operation. So the key message is that maturity is not achieved by adding more committees, but by building systems that reliably produce high quality of care and reduce harm, supporting the continuous improvement. So here we highlight how advanced organizations integrate clinical governance with corporate governance. Clinical governance must be embedded into the enterprise risks. Quality and safety KPIs should sit alongside the financial and the operational KPIs in the executive reviews. Assurance reports should be across all domains, must follow unified escalation pathway. So when clinical governance is isolated, the organization will miss critical signals. When integrated, the leader gets a complete view of the organizational health, financial, operational, and clinical, allowing for balanced and safe decision making. So high reliability organization operates safely despite complexity. Their five principles is preoccupational with failure, sensitivity to operation, difference to expertise, reluctant to simplify, and commitment to resilience fit directly within the clinical governance. For example, the preoccupation with failure appears in the early warning system. Difference to expertise appears when frontline clinicians escalate concerns. Resilience appears in continuity of safe care during crisis. So high reliability thinking evaluate governance maturity. In mature system, workforce capability is treated as the governance risk, not just an HR issues. This includes competency gaps in high-risk services, leadership turnover, burnout, staffing reliability. So many adverse events are not caused by poor clinical skills, but by systems and capability gaps. So here in clusters and network or multi-facility system, the governance must operate across the organizational boundaries. Advanced governance practices include setting system-wide safety priorities, standardizing the pathway across the facilities, ensuring shared learning from harm events and balancing central oversight with the local accountability. Fragmented governance across hospitals creates variation and unmanaged risks. So, mature system build coherence across facilities. So, whether a patient goes to a hospital A or B, they receive the same safe, evidence-based care. So, measuring clinical governance requires evaluating the governance effectiveness, not just clinical outcomes. Impact indicators include reduction in serious harm, closure rates for high risk actions, re audit compliance, time taken from incident to improved system changes, and executive decisions turnaround times. So, if governance does not change outcomes, it must be redesigned. Here we can see the measuring the so when implemented and governance at maturity level, the governance become a strategic advantage. It builds the trust with the patient, regulatory, and the staff. It supports the safe innovation and transformation, and it strengthens the accreditation readiness. Also protect organizational reputation and sustainability. So the key message is that clinical governance is not about controlling. It is the engine of high performance healthcare system. The concept that the clinical governance at the advanced maturity become a system of systems, it integrates care delivery, risk and safety system, workforce reliability system, digital information systems, and the improvement system. So failure rarely occur in one system alone. They emerge from misalignment across the systems. So that means the role of the clinical governance is that the organization is to ensure a coherence between these interdependent systems so that the organization operate reliably. This systems thinking approach is critical for modern healthcare complexity. So, clinical governance, one of the most overlooked governance responsibility, variance in clinical practices. So, not all variation is harmful. Some of the intentional and unnecessary for patient complexity, but unwarranted variability not explained by patient need or evidence, is a governance failure. So, leader must identify variation in outcomes and understand the root causes. That means data help them to distinguish appropriate clinical judgment from practice drift and outdated habits or system weaknesses. So clinical governance don't replace clinical autonomy. It protects and enhances it. That means the governance provides boundaries for acceptable practice, ensure decisions are evidence-based, and supports the escalation for high risks or uncertain situation. It protects the clinician with a clear policies, shared accountability, and structured decision pathways. So when clinicians feel supported, not controlled, decision making become more safer and more consistent. Innovation introduces opportunity but also risk. So that means innovation without governance can be lead to unsafe experimentation, while governance with innovation leads to stagnation. So advanced clinical governance defines structured approval pathway for clinical innovation. That includes risk assessment, pilot testing, define the success criteria, and ongoing safety monitoring. So the governance ensures that new technologies, pathways, or models of care are adopted safely and do not introduce unintended harm. So strong governance enables innovation to flourish in a controlled and safe manner. In crisis, such as pandemics, system lock shocks, or capacity strains, reveal true maturity of governance. So, resilient governance is characterized by clear command and structures, rapid escalation mechanism, dynamic risk assessment, and protection of core safety standards under pressure. So during crisis, organization often drift into a reactive mode. Mature governance maintain decision discipline and ensure the safety remains non-negotiable priority. Here we are going to explore the future-ready clinical governance. So it shifts from to future trends, from future-ready governance, while future-ready governance focuses on predictive analytics, cross or operational systems, work sustainability, and integrating value, outcomes, and equity. Healthcare complexity is increasing, and the governance must evolve accordingly. So, future governance framework prioritize foresight, anticipating risks before they materialize, and building systems that adapt continuously. So the governance cannot remain static in a dynamic healthcare environment. It must evolve to protect patient safety and system integrity. Clinical governance is not about control or perfection. It is about stewardship and reliability. So, excellence in healthcare comes from systems that detect problems early, respond openly, and improve visibly. So, the governance is not only about compliance, it's about earning trust from patients, staffs, and regulators. So, the leaders must think differently, decide differently, and learn continuously. So organizations that understand governance as a mindset, not a checklist, are ones that truly achieve excellence. At advanced maturity, clinical governance is guided by intelligence, not raw data. So data must be converted into insight, converted into judgment, and judgment into decision. So a leader must understand why performance changed, not just what changed. This requires narrative supportive dashboards, fewer but more meaningful indicators, and clear implications for action. So the governance intelligence enable leaders to detect weak signals, anticipate deterioration, and make high quality decisions. Data should guide judgment, not overwhelm it. The governance maturity is reflected in how leaders make decisions, especially under pressure. So, decision discipline includes clear escalation thresholds, consistent response to similar risks, timely decision aligned with the risk's appetite, and documented rationale. Inconsistent decisions create latent risks and erode trust. So the staff learn far more how leaders behave than or than from what policy says. So consistency, transparency, and timelines in decision making are foundational to reliable governance. Healthcare organizations are stewards of public trust. So the clinical governance protects that trust through transparency, ethical use of data, honest communication with patients when harm occurs, and responsible reporting for regulator. Governance must also ensure protection for vulnerable population. So the governance is the mechanism through which this trust is earned and sustained across the communities and systems. At its highest maturity, the clinical governance leaves a legacy. It creates a workforce that feels safe to speak up, leaders who are fluent in quality and safety, and systems that continue to improve year after year. So the legacy level governance provides reliable outcomes even as the conditions evolve. It reflects not only what the organization does, but what it stands for. So the clinical governance becomes the enduring philosophy that defines the organization and identity and strengthening its future resilience. The future of the clinical governance will shift from oversight to foresight. Instead of we asking instead of asking what went wrong, organization will ask what is likely to go wrong next and how do we prevent it. So predictive analytics, system safety intelligence, and proactive risk sensing will drive this shift. So the governance will focus on anticipating system stress, identifying emerging risks, and enabling rapid adaptation. Foresight-driven governance ensure that the systems stay ahead of harm, not behind it. Here, this is the characteristic of future-ready governance systems. They continuously scan for weak signals, use real-time feedback loops, and adapt controls as conditions change. So learning governance systems evolve with the new information, new risks, and new clinical realities. They don't rely on periodic review, they operate as a continuous sensing and learning engines. This adaptability ensures long-term system resilience. In this slide, we highlight how governance must evolve as a healthcare shifts to integrate and value-based care models. In these models, quality is measured across the entire continuum, not just within the individual facilities. The governance must therefore oversee outcomes across the pathways, ensure shared accountability across the organization, and monitor the balance between the cost, quality, experience, equity. So integrated care requires governance structure that connect hospitals, primary healthcare, community services, and partners. So the governance cannot remain siloed. It must support coordinated, patient-centered care delivery. So here in future, governance literacy will be defining leadership capability, and clinical leader must understand system design, risk principles, the safety science, the data interpretation, and the improvement methods. They must lead, not delegate, clinical governance because it is fundamental to prevent to patient safety and organizational performance. So the future leaders must balance innovation with protection and value with equity. The organization that invests in building governance capability among leaders will develop a resilient, empowered leadership pipeline capable of navigating complex healthcare environment. So here a powerful vision. Clinical governance is no longer optional or supportive. It is central to organizational success. It is the architecture of the trust, the engine of quality and safety, the enabler of sustainable transformation, and the moral compass of the healthcare leadership. So the systems that master the clinical governance will not only prevent harm, they will set new standards of excellence in their organization. This is the shift from viewing governance as an administrative requirement to seeing it as a strategic, future shaping capabilities. Thank you so much for listening. Now we open the floor for question and answer.
Thank you so much, Dr. Naifah. So if you have any questions, please feel free to type them in the chat box or the question box, and we will give Dr. Hamoudah the opportunity to answer those questions. And while we're waiting to see if people put some things in the chat box, I just want to kind of summarize some of my key takeaways. It was really evident to me the importance of clinical governance, especially with the increasing healthcare complexity. I really liked some of the things that my takeaways were. I really liked that audit without action is not governance, and that data must answer the question about, what are we going to do differently? And I also really, saw the importance of that cultural maturity of moving from that blame culture to the reporting culture to the learning culture. So really great impact on the culture. We do have a question here for you, Dr. Naifah, and it's, how do you maintain version control of governance that ensures everyone across functions has the most current governance?
So now you hear me?
Yes.
Hello?
Yes, do you hear us, Dr.
Yeah.
Naifah?
No, just can you repeat the question?
Yes.
So yeah, you mean you ask about how we maintain version of control of governance?
How do you maintain version control of governance that ensures everyone across functions has the most current governance?
So the organization must establish a centralized repository. Example, a governance portal, document management system, where all approved governance documents are stored. This is one of the things. The other thing is assign clear ownership for each document. For example, the governance, the risk, the compliance, the quality unit, the responsible for updates, and who's responsible for the approval. Also, they can implement a formal version control mechanism where, ensuring that the dates, the revision, the approval signature, and all of these things. They can also communicate. They can do the audit compliance periodically to verify that the department are using the latest documents. This is what you are asking about. This is what I've heard about you.
Yes.
Is it right?
Correct. Yes.
Yeah. And also they can integrate version control into the governance cycle. So for example, they can do the development, the review, then the approval, do a memo or publication, monitoring, and then revision.
Thank you. Any other questions? Okay. Well, thank you so much, Dr. Hamoudah, for this very valuable and informative presentation. Hold on. We do have a question.
Okay.
Okay, the next question is, what are the best ways to raise awareness about governance at the institutional level?
Okay. So in best ways to raise the awareness about the governance about at the institutional level, the leadership messaging and the tone from the top. So that means the CEO, the executive council, for example, they have to issue a regular governance messages. The governance become part of the leadership meetings. Also, a monthly updates about it. Leadership leaders, so they have to do publicly model for compliance, risk awareness, decision making discipline. Also, we can do a visible governance framework and structure. So we have to publish the governance structure and the committee's escalation pathways and role. Make the who decide what chart easy and accessible. Also, we can do it a clear, a simple communication campaign. So a structured campaign for example, for a month or 2 months, including posters, banners, for example, short videos, digital screens, weekly governance facts, or for example, do you know messages? Also, we can do, for example, an awareness teams. You can also do the governance orientation for all employees. It's a mandatory for the new staff. A 60-minute and annual refresher for all leaders, clinical, non-clinical. Also, they can targeted the role-based training, clinical leadership governance, for example, corporate governance for support functions, risk management for department heads, compliance for supervisors. They can do an internal governance portal or a dashboards. And lastly, from my opinion, storytelling through real cases. Will be so much impactful. So case-based learning boosts retention by 70% compared to lectures. And this is what I did it in the last week. We have a governance lecture about it. Thank you.
Thank you. And just a comment from one of our attendees, they love the idea of annual governance training. So thank you for that idea.
Yeah, you're welcome. I hope that they will gain the knowledge and the benefit from it. I try just to make in these 40 minutes to simplify it for any level who's attending from the audience.
Wonderful. Thank you. Okay, it's your last chance to enter a question. Okay, well, thank you again, Dr. Hamoudah. I hope by sharing this information on clinical governance that we'll start to see that shift of what you said the question would be for future clinical governance, and that's to ask what likely will go wrong and how do we prevent it rather than what went wrong. So I wish everyone all the best. We will be sharing these materials with everyone so you can do your work on clinical governance within your organization.
Sure. I would like to thank you, Dr. Hoffman, for your giving me this opportunity to participate in your webinar.
Wonderful. Well, it was a pleasure to have you. I would like to close very quickly by sharing our next webinar, and that will be on our February 3rd Thursday webinar, which will be on QAPI, which is Quality Assurance and Performance Improvement. It's not just for long-term care anymore, and that will be presented by Kay Kendall and Glenn Bodenson with Baldridge Coach. And just a little bit about the webinar. When CMS piloted QAPI in 2011, no one could have predicted the impact that it would have had on the residents and patients in nursing homes. And by 2013, it became a requirement for centers receiving Medicare and Medicaid. And since then, CMS has continued to develop tools and resources to make this program effective in moving from being reactive to proactive improvement. So join us on February 19th for this presentation on why QAPI is no longer for just long-term care. I want to thank all of you for joining us. If you would like to start your performance excellence journey and you don't know where to start, here are the contact information for the programs that support this program. If you're not part of one of these programs, you can reach out to me and I will make sure you get connected with the appropriate program. With that, I would like to thank you for joining us and hope you can join us next month. And I would one more time like to thank Dr. Naifah Hamoudah for sharing a lot of valuable information on clinical governance. Have a great day, and we'll see you next month. Bye, everyone.
See you. Bye-bye.